So this exam is facial bones. We have multiple projections for facial bones. We have PA, blowout, Waters, SMV, and a lateral. So there's quite a few projections for facial bones. As we learn the different exams, try to remember that what are you x-raying? So this one happens to be facial bones that we're talking about. In the case of facial bones, what's in the middle of the facial bones? The tip of the nose. If you're doing mandible, what's in the middle of the mandible? Mandible's from here to here, lips. So when a lot of the projections are very similar and or the same, so it's very important to try to remember, if you get confused, remember what exam am I doing? And then that way you can figure out where your centering points should be. Okay, so for facial bones, we do a PA. So I'm going to have my patient face the board. I'm doing this one upright for you because I did the skull on the table, so now I want you to see how it works here at the wall. So for the facial bones, we do a PA. The PA is positioned exactly like the PA of the skull. We do the centering a little bit different. So what I'll do is have you touch your forehead to the table a little bit. And by doing that, what I'm trying to do is get her orbital meatal line perpendicular to the IR. So I'm using my straight edge, and I'm going to the outer canthus. Tuck your chin just a little bit. Okay, so I hope you can see what I'm doing here. Okay, so I'm using the outer canthus to the EAM. Tuck your chin just a little more. Good, okay. Stay like that. So now my central rate for this facial bones, PA facial bones, I'm at 40 inches. And I'm going to center the tip of her nose, because that's in the middle of her facial bones. Collimate at about 8 by 10. And I'm going to move this board for just a minute here. So then you line up your IR with that. And then of course I have to sneak in between here to make sure she's nice and straight. You can hold on down here if you like. And her hair clip would be gone. Her earrings would be gone. Okay, the next projection would be called a blowout. It's a modified parietal canthial projection. So the blowout is actually done for the orbits, to see the base of the orbits, to look for fractures. So it's an important projection if the patient has been in an automobile accident, a fight, or something where their orbits have been damaged. So we're at 40 inches, patient's shielded. I probably should put a shield on you. We'll do that for the next projection. Right marker is on the board. For this one, we want the patient close to the board, and we're going to have her touch her chin and her nose. Like that. And let's bring it down just a little bit. We start with that, and then we look at the acanthial meatal line. So the acanthion is here, just below the nose, and that line has to be perpendicular to the IR. Bring your chin up. It's perfect right there. Okay?
Got it.
Okay. So with that said, then that's our centering line. So I'm going to just a little bit. We're done with this. We're done with the tube. Don't touch it again. Like I said, she's shielded. Arms can be out a little bit just to balance, and legs could be apart a little bit. And then we just want to make sure that she is not rotated. And no hair clip, of course. And collimate to the orbits. This one's a little different. We use the acanthomeatal line as the line that is our centering line, but we want to move our actual light up and include the top of the orbit, the bottom of the orbit. I'm going to move my marker up to the top corner. And so I'm centering a little bit. I'm centering at the orbits and collimating in a little bit. Make sure you don't clip the bottom of the orbit. And I'll have her just like that. So you can see it's narrowed through here. I need to just adjust this a little. I'm going to adjust a little bit. There. So that's the blowout. The next projection for the facial bones is the Waters projection. This one is done to visualize air fluid levels in the maxillary sinuses. So it has to be done upright. If the patient cannot do upright, then you would lay them on the table and do a horizontal beam like a decubitus projection and shoot across table, and it would show the air fluid levels that way on the film, or on the image. For this one at the wall, we would have our patient close to the IR. I'm going to use 10 by 12 collimation and have her get close, and I may do a little adjusting here a little bit. Touch your chin to the IR. And for this one, we're going to make sure that the MML, which is the mentomeatal line, is perpendicular to the IR. So that's the base of her chin. And so I would do something like this. So that line is perpendicular. 10 by 12 collimation, I'm going to adjust this just a little bit. Your centering goes to the acanthion for this, which is just below the nose. Just have a slight adjustment there. Marker can be up or down, either way. I always mark the side on the outside where I'm working instead of reaching across in front or behind the patient. It just is smarter that way, it's quicker. Okay. Waters projection, head should be straight. You can see the difference when I have to go between the tube and the patient. It's a lot closer, and on the table you can actually see the entire body. So more chance for mistake here because she could move. She just mentioned that last projection was a little difficult to do. So if she's young, and she says it's difficult, then you can imagine if it was an older person. So consider the table for some of these, it can help. And you can certainly go back and forth from the table to the wall if you need to, according to your patient. So that's the Waters projection. The next projection I'm going to do is the left lateral facial bones. So I'm going to have my patient rotate about 45 degrees, and that way she can put her face close to the IR and face this way. Good. The infraorbital meatal line is now going to be parallel to the floor. Okay, so the infraorbital line is just below the orbit instead of at the acanthus. So we want that. Tuck your chin a little bit. There. So we've checked that, and we'll leave her there. Arm down. This one is done lengthwise, unlike the lateral skull, because we're just doing the facial bones. So I will move her back a little bit and put the zygoma to the center of the IR. I have to move the tube down just a little bit because that's above her zygoma. And then chin out and straight. Now, I cannot tell you enough how important it is to look at your patient from multiple angles, because many times they look straight and they're not. So I always go around to the front, excuse me, and I look straight at her face. Her interpupillary line has to be perpendicular to the IR. So that means this line right here. And what I want you to do is bring your chin out this way a little bit. There. Good. Sorry. Okay. And I'm going to put a marker on it. It's her left shoulder touching. So I'm going to put left up there. And so the centering part is at the mid piece, right at the bisected zygoma. And that should put her facial bones to the center of the IR. And I would just then, the last thing I would need to do is adjust my IR here. She's shielded, of course. And like I said, I have a left marker for her left side touching, anterior to the patient. Okay, now for the fun X-ray, the SMV, submental verticals. So what we're doing is we are going to have our patient lean her head back. Don't do it yet. We're going to have her lean her head back, and what I'm going to do is have the central ray go through her chin and out through the top of her head to the IR. So this one is very difficult for people that have any problems with their neck. So be aware of that. If they can't tip their head all the way back, you can angle the tube up toward the patient's cephalic to try to equalize the angle. What we're trying to do is make the central ray perpendicular to the infraorbital meatal line. And so now we'll just position. I've already kind of got her where I want her. I've got her on a stool. I guess I should give her a shield for at least one of our projections. So she's shielded. I have a 10 by 12 in the upright bucky and it's lengthwise. And I don't have it at 40 because I'm too close to her. If I do that, I have to sit in her lap. So what I'm going to do is push it back a little. As soon as I have her positioned, then I'll move my tube forward. And so what I'll have you do now is bend your head back. And we have a 10 by 12 collimation. We want to make sure that she's nice and straight. I'm going to put a marker on this, and now I'm just going to bring my tube forward. Might need to adjust my collimation, of course, because it was smaller. It's smaller up close. And I see her chin is rotated a little bit, so I'm going to turn her this way. Now, the infraorbital meatal line has to be parallel to the board. So let me just check that out. Tip your chin back a little bit more. Back more. There. You can see that's very difficult for the patient to do. And of course, now that the tube's in my way, it's difficult for me to check her. It's difficult for her to sit like that, so you want to be very quick about it. I would leave her like that. My tube is okay, my IR is okay. Maybe just a slight.